Welcome to this episode of CQC Connect. In this episode, we're going to explore our latest Out of Sight progress report. It's a progress update on the review that we did into restraint, segregation and seclusion in care services for people with a learning disability, autistic people or people with mental ill health. My name's Lizzy Dobres and I'm the Communications and Engagement Manager here at CQC. I've been involved in the journey of this report and I'm going to be hosting today's podcast. I'm really pleased and excited to be joined by Julie Newcombe today, who's the mother of an autistic son and who's the co-founder of Rightful Lives, a human rights organisation, and Debbie Ivanova, Deputy Chief Inspector for people with a learning disability and autistic people at CQC, as well as Amanda, who is also joining us. Welcome and thank you for joining us today. Can we start by introducing who you are and why this topic is important to you? I'll quickly go first, and then I'll come to Julie and Amanda and Debbie. So for me, it's probably as soon as I saw some of the conditions in the mental health hospitals around the country when we started doing the reviews in different areas, and we actually got to go into a lot of services and meet a lot of people that are in those units. And when I met with Julie and Alexis, I just really felt that we hadn't done well enough as a system and we needed to do a lot better. And the more families and people who I've spoken to, the more angry it makes me that we haven't really done better as a system to solve this problem quick enough. So that's probably it from me. So I'll go to Julie.
Hi, Lizzy. I mean, my autistic son, Jamie, spent time as an inpatient in the psychiatric system. And let's say it wasn't a very pleasant experience. You're talking about abuse, you're talking about over-medication, you're talking about isolation, segregation, denigration of the family, you know, nothing positive about the experience at all. And when I came away from that, when we finally got him out, and I met up with other parents who'd been through the same sort of situation, I decided, you know, we need to do something about this. So got into campaigning, firstly through 7 Days of Action. And then I co-founded Rightful Lives, which is a creative campaign, if you like, to look at the human rights of autistic people and people with learning disabilities. And one of the things we focus on is the issues around inpatient settings. And we have autistic people on our admin team who are all very committed to contributing to solutions and raising awareness. For me, I mean, the crux of the matter is you go back out over all the years, even pre-Winterbourne View, people have been saying for ages, this needs to change, this is horrific, this isn't good enough, and governments promised change, and then governments failed to deliver, and services have failed to deliver, and it stays the same. So that's why this is really important for me.
Thanks, Julie. And Amanda, why is it important to you?
Hi, I'm Amanda. I have lived experience of autism and also chronic mental and physical illnesses. I've had a number of psychiatric admissions over the years, and I have experienced being put in segregation, being put in seclusion illegally, and have some downright dangerous incidents when I'm meant to be in a care setting. I've been working alongside the Care Quality Commission and Choice Support as one of their experts by experience since 2016. And this has included advisory work and site visits, including a number of the visits that formed the original Out of Sight report. And it's been really challenging and emotive seeing the inappropriate care, but also seeing the few patches where there are good care and not having those celebrated and highlighted. And it's frustrating when you see that things can work well in one area and don't elsewhere.
That's really great. Thanks, Amanda. Finally, Debbie, over to you. Why is this important to you?
Hi, everyone. I'm Debbie Ivanova, and I'm a social worker by profession, and I've worked really most of my career has been about working with people with learning disabilities, both in this country and in other countries in Eastern Europe. But with this particular review, I've been involved now over the last 3 years, and it's because of this review that I'm actually doing the job that I'm doing right now. we could see the problems that so many people were experiencing and the harm coming from the overuse of restrictive practice. And families were telling us how urgent this situation was and how much things needed to change. But families were also saying, Debbie, you can do more. CQC needs to play a bigger part in that change. And so I was really keen to help us as an organisation to lead that change. And my role came as a result of that work and that challenge from the families that we worked with during the out of sight review. So what I'm now doing is trying to look at how we transform our regulation to really get under the care and support of people with a learning disability and autistic people in regulated services. So a real clear focus on stopping people moving into services that aren't safe, stopping services operating if they're not able to meet the needs of the people in those services, and using our ability to influence and improve services to try to make sure people get the care that they do need.
Thanks, everyone. Some powerful introductions there. So going to start with a few questions now, and I've got a question for you, Debbie. The progress report highlights that some work is underway to try and fix a lot of these problems, but so much more needs to be done collectively, especially around restraint, segregation, seclusion. Can you tell our listeners a bit more about the report and what it covers?
Okay, so the report's written in a way that brings together our findings on each of the 17 recommendations that we made in the original report, but it focuses in on 4 things. What difference would it make for people if this recommendation was fully implemented? What progress has been made to make that recommendation a reality? What have people using services and their families told us about what's happening to them now? And then looking at what are the gaps. So this progress report, I think, is really important because it's about keeping up the pressure, keeping the focus and continuing to shine that light on areas where we still haven't seen enough progress. We can't allow COVID to be a reason for not putting renewed energy into getting this agenda sorted. As Julie said, this has been going on for years and we keep saying something must change and we can't allow that pressure to stop. So this report does show some of the promising signs, such as the introduction of some new schemes and programmes. And an example of that, which I'll mention, is the HOPES programme. So NHSE have commissioned Merseycare to offer a programme across mental health, learning disability and services for people with autism. And this programme offers training, support and clinical interventions to reduce restrictive practice, develop positive cultures, strengthen clinical leadership. But there are lots of those little initiatives. It really isn't enough. For people with a learning disability, the range and availability of community support and places to live hasn't developed sufficiently. We're not seeing enough bespoke support for autistic people without a learning disability, and we're seeing real problems around access to community mental health support. So the report does give a balanced view, but we have to be really clear that not enough has changed.
Thanks, Debbie. And it's clear what you say about, COVID. I think it's important we think about that, but at the same time, it's not an excuse now, especially where we are now, to not focus on this again and make sure that we can get the change that's needed. Were there any, overarching themes that came out particularly in the report that the system needs to focus on for improvement, especially around restraint, segregation and seclusion?
There are still too many people in settings that rely on that restrictive practice. And too many of those settings are focused on containment rather than recovery. The problem we have is that the right support isn't available in the right places. So people aren't getting the support to stop them going to hospital and not getting the right support to help them get out of hospital. So that means that there are still too many people in hospital. We're still hearing too many stories of inpatient units where there's poor care and treatment. We're also hearing that the care education and treatment review process isn't working well enough. It needs to become statutory so that people must implement the recommendations that are there. They're a good process, but unless those things actually result in change, then it's not enough. We're hearing that people are still finding access to community mental health, as I mentioned before, more difficult. Obviously, the pandemic has contributed to that, but being able to get that support at the right time early on to stop people becoming more unwell really has to be a focus going forward. More autistic people without a learning disability have also told us they feel that they're hidden from services. That needs to change. People with lived experience, their families and commissioners tell us that there's not enough provision of housing with the right support available. So those are some of the really strong themes, I think, that come through in the report.
Thanks, Debbie. And Julie and Amanda, do those themes resonate with you? How do they kind of chime with your own experiences? Maybe I'll go to Julie first, that's all right.
Yeah, I mean, just to come back on something Debbie just said about DTRs being made statutory. With that, we have to have the power to enforce where laws are ignored. And that happens already. Laws like the Care Act or the Autism Act or the Equality Act, the Human Rights Act, etc., long list. And these laws are ignored. So I sometimes think that, asking for statutory implementation isn't necessarily the answer unless you have within that the means for people to get that enforced if it's not happening. But yeah, to answer your question, Lizzy, I think it's worth saying in terms of personal experience, and this is the truth for a lot of people, that I think there's a saying that the ATU is the last stop on the SEND journey, SEND journey. And I think there's a lot to be said for that. So when we talk about how we improve things in inpatient units, I think we need to remember what's led up to that. And certainly in our case, with Jamie, it was very much the lack of the right support as a child when he went into a crisis that then led on to several failed residential school placements over several years and culminated in detention under the Mental Health Act at the age of 18. At that point, that's already avoidable if you'd had the right support at the right time. Once in hospital, of course, that's it. It's very difficult to get out, as we know. He had a broken arm, he had other injuries, he was over-medicated. Well, to the point where he couldn't stand up, he couldn't speak, and a nurse had to refuse to give his medication to him because she thought his life was at risk. And I could spend the rest of this podcast discussing some of the stuff that happened to him and that happens to other people, and it's happening right now to people. Jamie's been out of hospital for several years, but he's still traumatised. He has a PTSD diagnosis. His nights are still disturbed. And aspects of how he is, how he feels about himself and how we see him are so different from pre-hospital. He's been damaged. And this doesn't sort of get undone the minute you walk out the hospital doors. It's lasting, and it lasts for years. And then you wonder why, and this happens to lots of people, you wonder why care becomes more expensive once you come out of hospital, because not only are you having the original needs met, you've got a whole truckload of other needs to be met that didn't exist before you went into hospital. But to give you a positive note on all this, Jamie's now living in his own home in an area that he chose to live in. It's been adapted for him. So, things like the colour of the paint on the wall, making it a low arousal environment, him being part and parcel of choices in how it's laid out. Where the train track is very important, stuff like that. And he has a wonderful, wonderful staff team who are well trained, who are just such a great bunch of caring people and who understand him. And this is what people need. They need the right kind of support, the right kind of living arrangements which reflect the fact that they may have had traumatic experience. And to emphasise as well, the importance of life planning, which I think is starting up now. Life planning can really help with identifying a person's history and then with getting to grips with what they're going to need when they're out of hospital. And it's all about, what are your dreams? What do you like doing? How do you like to spend your days? What's important to you? What don't you like? And giving the person a choice over how things are done rather than imposing it on them. It's all part and parcel of making it work for me.
It's not rocket science, is it?
Hardly.
No. And Amanda, what are some of the themes from the report that resonated with you, and how does that chime with your own experience?
Yeah, Lizzy, I've been in mental health services since I was a child. Don't remember exactly how old, but end of primary school, start of secondary school age. And I've had some better experiences and some absolutely awful experiences. So I'm going to try and say the positive things first, but they have to be balanced with the negative stuff out there. So some of my better experiences of community care have been when there's been continuity of staff, so people can really get to know you and work out how you respond to things as an individual. And even if staff do change, that there are handover process that involves me as a patient. I've really benefited when services or individuals within services have thought outside the box a bit, that medication and hospitalisation aren't the only options. So I was fortunate in the past to get a PHB, a personal healthcare budget, which enabled me to do some training, which even actually got me back into part-time work. And I've also had in the past day services that have stopped me, been sufficient support to stop me from being hospitalised. And the big thing for me is trauma-informed care. There's lots of research out there from lots of different organisations and individuals to say that people with disabilities, particularly children with disabilities, including autism, including those disabilities, are more likely to be traumatised or abused. So you've got that trauma in the first place, and then, like Julie was saying about her son being hospitalised and in a restrictive environment adds further trauma to that. So trauma-informed care. However, some of my poor experience of really poor community care has been when there's been lack of communication between different services. So no one knows what the other doctor or nurse or team is doing. I've even come out of hospital without a discharge summary despite medication being changed. And then you try and get your GP to change your meds. And I've frequently experienced what could be termed passing the buck, when there's an unmet need and every professional assumes that someone else is dealing with it, but actually no one is, so you fall through the system. I've faced a lot of time where people have tried to medicate my autism as opposed to my mental health conditions, and because I stim, so I quite often have repetitive movements, sometimes make repetitive sounds, and people try and control that with medications despite things like the stomp principles. You know, if my movements are not hurting me or anyone else, why should they be medicated? Inconsistency in staffing, and a big one going back to trauma-informed care is being denied access to talking therapies or other creative therapies because I have an autism diagnosis, despite all those stats about more likely to be traumatized. And inpatient care, my better experiences have been when the team have done what they can within the building to make the environment a bit better for me. So there were wattage light bulbs, putting me at the end of the corridor so there's not noise of people going past, particularly when they've spoken to my GP or medical teams, and when they've looked after my healthcare. And when we've found effective care planning, such as I use the Q card system, and I've tried to implement that in other admissions, and it's just been ignored despite the fact that it's worked in the past, and that's really frustrating. But like Julie was saying about her son, some inpatient care is just horrific. I personally have been put in seclusion and segregation illegally when I wasn't even under a Mental Health Act section. But at that point in my life, I didn't know enough. This was well before I started working with CQC. I didn't know enough about the Mental Health Act to know that what was happened was illegal, but I wasn't in a very good place anyway, and that made me so much worse. Yeah, sensory overload because of the environment of the hospital. There's always lights on, usually fluorescent lighting. There's always noise and movement. Quite often you have conflicting noises, so there might be in one area TV and one noise and a radio and people walking past and talking. And if you're in a hospital that insists you can't spend your daytime in the bedroom, but you're subject to that in the communal areas, and then they wonder why you get stressed. I've had threats of restraint and threats of the Mental Health Act and forcible medication. And I appreciate the out of sight report was looking at actual restraint and seclusion, but coercion and threats is just as much of an issue in my personal opinion. And delays to discharge, not even just one delay, but multiple delays, and you get yourself mentally prepared to be going home on a certain date and then to put back a week and another 2 weeks, and that can instill a sense of hopelessness in itself. So mixed experiences.
I'm really sorry to hear about some of these experiences, Amanda. I mean, like, I think we're all like completely shocked that this is still happening, right? You know, in a lot of hospitals across England. Like, in fact, most of the mental health hospitals I think we've seen have some kind of restrictive interventions, and a lot of people have had negative experiences of those. I mean, I think we're all collectively really frustrated, and I think people listening to some of this for the first time will be shocked again, as many of us were at the beginning of this journey, that this is still happening, like, you know, in the 21st century in hospitals. So it is really frustrating, but it was good to hear, Amanda, about some of the good things that you've experienced and some of the better care that you have started to experience. It's just a shame that it took you so long to be able to get that, and that the responsibility, it felt like, was on you to inform yourself about your own rights and to kind of advocate for yourself instead of the system being there to support you. So sorry about that. So next question that I've got is about the barriers. You know, we've talked about, I mean, me and Julie have talked a lot about, you know, it seems really simple, like it's not rocket science, but yet here we are. So what do people think some of the main barriers are? If you don't mind, Amanda, I might just go to you first again. Like, why do you think this isn't better? Like, how do we overcome it?
Thanks, Lizzy. There's lots of different barriers, and I think it does depend where you live geographically in the country as well, because services are variable. One of the big issues, I think, is that support for complex needs isn't integrated. Mental health care comes from one organisation, physical health care from another one, social care from somewhere else. That there's no link up between professionals, be that healthcare, social care, third sector, despite, again, there's research that says, and stats that say, people who are autistic or have learning disabilities are more likely to have comorbidities, other illnesses at the same time, but their care is often disjointed. For me, a personal example of that is times I've tried to avoid hospital admission and access respite care, but the physical health respite care settings wouldn't take me because of my mental illness, but the psychiatric ones wouldn't take me because I had to use medical equipment, be that a catheter or a feeding tube. Even though I use them independently at home when I'm well, they refused it. So I had to be hospitalised because there wasn't appropriate respite. Another thing that I feel is a barrier is how services are planned. They tend not to be planned in a way that aims to keep people in the community. It seems like hospitalisation is the default for a crisis, not the last resort. In the part of the country where I am at the moment, there is no specific autism support within my mental health team, and it's a large team that covers a big geographical, highly populated area. And if you have an average or high IQ with your autism, then you are not eligible to access help from a learning disability specialist nurse. But that doesn't negate the fact that autism still impacts on your life and your quality of life. One of the things Debbie mentioned early on was about CETR's care, education and treatment reviews, that this has been, they've been around since I think 2015. They've been best practice since the 2017 NHS England advice. It was reiterated in the Out of Sight report in 2020, yet there's so much variance on trying to get them done if you can at all. And the recommendations talk about people who are high risk of being hospitalised having them done before they end up in a hospital setting. At the end of last year, I had a dip in my mental health because of some reasons, and hospital was being talked about, and I asked for an ICTR. I asked 4 different clinicians and the patient advice and liaison service, and not even the doctors or the senior nurses knew what a CETR was, let alone how to access one, despite this having been best practice since 2017, being a thing since even before then. And the other big barrier that I personally have found is even when hospitalisation may be necessary for someone's safety, and I'm definitely of the opinion that therapeutic risk taken in the community is often the preferred option, even when that is needed, it's once you're admitted, discharge plans aren't always started and you can be stuck there. And the current NICE guidelines talk about autistic patients in hospital being in small units with appropriate environments, but those places barely exist, and even the few that do exist are so oversubscribed that you can't get there. So you so often put somewhere inappropriate that you're either overstimulated or inappropriately medicated, and therefore what clinicians would view as challenging behaviour, be that too much or too little of a behaviour, can escalate, and therefore you're considered more ill, whereas actually it may not be your mental health problem that's deteriorated, but because of the setting you're in affecting your autism, you're perceived as worse than you actually are. So, but there's more things than that, but those are the first ones that come to mind for me.
Thanks, Amanda. And Ginny, what about you? What are some of the kind of the key barriers you think there are?
Well, as Amanda said earlier, you know, it's completely the wrong environment, and completely the wrong environment. It's too big, it's too noisy, it's too bright, it's too everything. I mean, and I've got it here. It says in the Mental Health Act Code of Practice that compulsory treatment in a hospital setting is rarely likely to be helpful for a person with autism who may be very distressed by even minor changes in routine and is likely to find detention in hospital anxiety provoking. Sensitive, person-centred support in a familiar setting will usually be more helpful. So that's statutory guidance in the Mental Health Act, and it's been there, you know, for as long as the Mental Health Act's been there. So why is that ignored? Why is that ignored? So I'm going to defer to Amanda on her descriptions of the environment and her autistic experience of that. But yeah, absolutely. And if you put someone in a situation that they can't tolerate and expect them to behave in a way that you're imposing on them, then it's not exactly going to be very easy for that person to succeed. Other things that I've thought about that I'm not sure have been mentioned yet are things like perverse incentives in the private sector. And we know that 50% of the beds roughly are in the private sector. And we know that the perverse incentives there are for profit making rather than patient-centred care, in my opinion. Other perverse incentives which exist are the financial difficulties in terms of people coming out of hospital that may be 100%, well, is 100% funded by the National Health Service to a setting that needs to be funded at least in part by the local authority. And the local authority budgets being as tight as they are, they don't necessarily want to be too quick to take on the responsibility for the care of someone who would otherwise not, you know, be funded by the NHS. So there are financial issues here. The workforce is poorly trained, poorly supervised and poorly paid. And I know there are some great people working in these hospitals for sure, who deserve much better than that. But sadly, the way things operate, it's too easy for the closed cultures to develop. Other barriers to discharge for me are lack of the right housing and very much poor local commissioning, decision making, and lack of follow-up where people are in services. And these are the sorts of things that need to be resolved, with accountability at local level being more, you know, required. We might actually get further, but there isn't any accountability really for poor commissioning decisions. So I think what we need going forward is a rights-based approach. Human rights need to be at the core of this, as I think the Hopes scheme says that too. We need accountability. We need upfront, ring-fenced, audited funding for community services. But as well as all that, we need trust. And the way I describe trust is, you know, let's have proper consultation with people and families. Let's make sure families can raise concerns safely. let's not other people with bizarre language that professionals like to use, you know, with these words like activities of daily living, which you only have to do if you're in health and social care. You never get to do them if you're just living a normal, ordinary life. But, you know, suddenly if you're in health and social care, you have a whole new vocabulary and a whole new language, and that does other people. It makes them different, and we shouldn't be doing that. So those are some of the issues for me.
Thanks, Julie. I guess, Debbie, sitting, you know, in the position you do, what do you make of what Julie and Amanda says, and like what do you think are some of the other barriers?
Well, I think they've summed up really well a lot of the things that I did have on my list, and Amanda and Julie, I think, you know, that your understanding of you know what gets in the way is absolutely right. I suppose if I wanted to kind of polarize it to two things, I think there's just that lack of a sufficiently joined up approach, and there's sort of, it sometimes feels like there's mistrust and a lack of partnership working across the sector, between health and social care, between children's service and adult service, between mental health and learning disability, and we end up those being barriers to people working together rather than looking at and recognising the whole person. So people end up moving around the system, becoming more likely to be distressed, and I think you described that really clearly, both of you, and then people get more unwell rather than better. So I think we've got to focus on partnership work, and we've got to focus on people and people in the services, not the service itself. We've got to think about what is the right support for that person. How do they get access to it at the right time, with the right thresholds, allowing people to get what they need, where they need it. We've got to get it right first time. We can't have people just going round and round the system in this way. Now, I guess for me, underpinning all of this is funding and commissioning. These really do need to be tackled. And again, I mean, Julie's talked about some of the perverse incentives and things, but what I think the answer has to be is that local areas, ICSs, need to accept the responsibility for the services in their area and get those plans in place. How are we going to meet people's needs now? Start to look at future needs. What do we need for the future? And I think we've got to really get a different kind of view on some of this. Start thinking community, start thinking citizenship, and what can really strengthen those local communities to recognise and respect every individual and think about what they need within that. So I sometimes think I sound a bit like my dad, who used to be a bit of a preacher, but you get into this place where you think, we've got to stop some of the things that we're doing. We've got to stop thinking in silos. We've got to stop thinking services. We've got to start thinking person in a much stronger way, starting with, you know, where do people want to live? What is the support that they need? We've got to change our approach from thinking about placements to finding a life for people, and those things that Julie was saying about, you know, the activities of daily living. We've got to get away from that. We've got to think about what is our ambition for people and their lives, and really make a difference in the way and the approach that we have.
So Debbie, what are some of the kind of real issues with like inpatient mental health services at the moment?
So what we've got to think about is, how do we really improve the care that's delivered in hospitals? I think that means that what we really need to focus on is, what is the model of care that we actually want, and what is the culture of those services? For me, the most important thing is culture. How is the service recognising and respecting each person's humanity, each person's rights, each person's aspirations for their lives? How are staff working with each individual to plan their care around those things? Recruiting, training and supporting staff, I think it was as Julie said, you know, is essential to getting this right. Perhaps what we need to think about is that sort of high quality specialist care for people who are in hospital, which hopefully will be for a very short time, and it should start by focusing on discharge. So what does that mean for people? I guess it means that people would only be admitted to hospital occasionally, as a last resort, and for the shortest time possible. So rather than thinking about how many hospitals do we need and what do we need, it's thinking about actually how do we meet that? The focus right from the beginning needs to be on discharge, and planning for that would start before you're even admitted. So people would be properly involved in that planning alongside their families and all those involved with their support. Perhaps people would be assessed by community teams before admission, so people who actually understand them and understand their needs. Back to what Amanda was saying about having that care, education and treatment plan before you go into a hospital setting. Objectives should be set, what is this placement for? What's it going to actually do? And then measured so that people are actually getting high quality care for that short period of time to get them back out again. What that might look like, it's going to be an appropriate environment for that person or a small group of people. So it could be small crisis units in a locality for autistic people, specially designed to meet their needs with that really high quality care and support within that service. While in hospital, people should also be getting the assessments they need. So if they need screening for autism, their sensory needs, their physical health needs, their mental health needs, their learning disability, of course, trauma, which we've talked about a bit, and any other relevant assessments, so that the objectives that are set on admission are revised and accurately reflected in people's care plans to meet their needs. So, I mean, that sounds like a lot, but actually it's not. It's about making sure that people experience person-centered care that centres around their needs, their specific needs, their trauma, and in environments that are therapeutic and based on that culture of value and respect.
And Amanda, is there anything else that you wanted to add that really, that kind of some of the fundamental problems with inpatient care in England at the moment?
Yeah, as Debbie said, it really needs to be person-centred. We should be tailoring the care around the needs of the individual, not expecting them to fit into a structure that's already there. And if they don't, then they get excluded or restrained or injected with rapid tranquilization or whatever, and linked up care with the community, with the medical health needs. I think one thing that really has irked me on almost every psychiatric commission has is the activities that are provided on the ward, assuming they even go ahead, which half the time they don't because there's not enough staff. Are they really meaningful and individualized? Like, there's a few adults I know that would like colouring, but many people, an hour colouring in colouring pages with heavily supervised pencil crayons is not meaningful and is not going to help them get back into the community. If you're going to do cooking with the occupational therapists, are you cooking something that you actually want to eat, that you might eat and prepare when you're back at home? Or are you cooking something that is deemed easy for a group of 6 people who can fit in the kitchen to cook together? So the activities need to be meaningful. And with discharge planning, I would love to see levels of step down services. Day hospitals are out of fashion now, but my personal experience is they've helped me go from that inpatient thing to having daily support, but without the restrictions of a hospital, but having the consistent staff, people I know, a place I know, having that step down to facilitate earlier discharge, but still with support, whether that's a day hospital, whether that's something else. But yeah.
Thanks, Amanda. I think, some of what you just said, it's just like treating someone like a human, like a person, like, not offering an adult a colouring book for an activity. Like, I think it's pretty common sense to know that that's not okay and it's unacceptable. So why would it be acceptable in somewhere that you're meant to be receiving care and treatment? Julie, is there anything else you wanted to add?
Not a lot to what Debbie and Amanda have already said, although, we have to ask ourselves if inpatient care really is needed, if we did get community care right, if we did get crisis care right in the community, do we even need inpatient settings? Maybe for a few people, but not many. So the thing I would add to that is if you are going to have them, you let autistic people design them because they'll know what's going to work.
Yeah, that's exactly right. And that kind of follows on, I guess, to my next question, which is like, what does the gold standard of like good community care look like? What does it feel like to be in, and how do we get there? I'm going to start with Debbie and then I'll go around.
I think the most important thing with community is that services are designed around individual needs, but that they are accessible at the right time for people, so that when people need to get access to the services, they're there, that they're services that are designed to give the level of support that people need, help them to stay where they are whenever possible and to continue to live in those services. What I hear from many people is that the ambition for people in community services isn't enough. And it is about that ambition to be able to support people to live a really full life within the community. That has to be what is aimed for everyone. Everyone has a right to that. I think Amanda's comments about, the appropriate things that people are given to do, I mean, that's just as much. We don't talk about people. We don't talk about I'm going to access the community this weekend. I'm going to go for an activity by going to the pub. We go to the pub. We go out for the day. We do voluntary work. We get involved in things in our communities. All those things that make us people of value. And I think those things are really important.
Thanks. And what about you, Julie?
Well, there's the obvious things, I think, like obviously invest in housing, invest in the workforce, make sure you've got good community teams with psychology, speech and language therapy, occupational therapy. Make sure it's not psychiatry led. It should be led by therapists really. And then good crisis support if needed. But I think, we could be ambitious and say, if we have good systems, we might not even get to crisis. Those are perhaps the more, the three obvious things that I would always say. But I think as well, we need to make sure that we empower people. So we need to locally have more joined up thinking between education, social care and health, as Amanda mentioned earlier. We need to start early. We need to give proactive support. We need to give people choice over their lives, and we need to give them financial freedom to do that. And most importantly, I think we need to put the voices of people with lived experience at the forefront of decision making and system design, not just with a token involvement.
Thanks, Julie. And Amanda, what about you? What would really make the difference?
I totally agree with Julie about patient-person involvement not being tokenistic, whether that's the person when they're a patient or accessing social care or their loved ones. They need to be the driving force. I feel continuity of care. I already mentioned earlier about handover when new staff come on, but an example in my local area is I'm now without a care coordinator because rather than providing people with continuous care who are likely to need it, you have to have a goal in mind to work with a care coordinator towards, and once you've either reached that goal or it's no longer considered achievable, you're discharged, and then you'll have to wait to see the doctor and they have to give you another goal, and then you have to go on a waiting list for another care coordinator, and all that inconsistency then means you're more likely to hit crisis and be hospitalized because you've not got that named point of contact. Things need to be flexible. Yes, autism and learning disabilities are lifelong things, but other things, stressors because your house isn't appropriate, stressors because you've just lost your voluntary work or you've had a bereavement, they can make illnesses or presentations different at different times, but services aren't always flexible to meet those different needs when you might need a bit more or a bit less input. People willing to take therapeutic risks or positive risks, don't say someone has had this incident, they must be put in hospital to keep them safe. How about thinking, what can we do to help this person stay safe in the community? Can we put in equipment, support, whatever? And two things that I'd like to throw in as what would be my ideals would be budgets that go across health and social care and follow one individual, and even complex care consultants, for want of a better phrase, someone, or just letting a GP who's known their patient for years potentially have authority to say, this person may have a mental illness of depression and anxiety, but they also have autism, they also have this stomach problem, they also have housing needs. Someone who can oversee all of that for individuals with complex needs. But I know they're big changes.
Just because they're big doesn't mean that they're not needed. So this might be hard, Amanda and Julie, but if you could ask for one thing that could really change in the system, what would it be? Shall I go to you first, Amanda?
Thanks, Lizzy. As we've discussed, there's so many things, but I think the key thing for me would be access to care at the point of need in the community. If things are beginning to escalate, being able to get the support as soon as possible, as active and flexible as possible, so that hospitalisation isn't considered the only option. That would be my main thing, but there's so much.
Thanks. And what about you, Julie? What's your one thing? And Julie, if you could change one thing, what would it be?
I think we should definitely take a close look at commissioning and supporting commissioners better, possibly by membership of a central body in the same way as other professionals are, that could provide training and CPD and possibly examinations if necessary, all that kind of support that commissioners could have. I do think we need to possibly regulate commissioning more closely because commissioners have an awful lot of money at their disposal and a lot of power over people's lives. So I think we definitely ought to be taking a long, hard look at how commissioning functions and how that can be improved.
Thanks. Okay, well, it's been a really interesting discussion. I think everyone shared some really interesting ideas, some quite powerful and personal stories as well. So special thanks to Julie and Amanda for that. And I know you've both told your stories probably upwards of 100, 200 times to different people across the system. So really appreciate you telling our listeners your story again. I hope it will make a difference and I hope people will listen to it and take action as a result. So if you wanted to find out a bit more about our Out of Sight Who Cares progress report, it's on the CQC website. The link should be in the bio in the podcast description, and you'll be able to find all about the report there. Thank you for listening. Please do keep up to date with all of the work we're doing to try and transform the way that CQC can change services for people with a learning disability and autistic people in our blogs, bulletins, etc. And other links are in the podcast description too. And we've got lots more CQC podcasts coming up, so please do look out for those soon. And thanks again.